Hello friends, in this session I will be talking about the tumors of the pancreas and especially the pancreatic ductal adenocarcinomas. So first of all, the pancreatic tumors can be divided into three types. They may be cystic tumors, they may be pancreatic ductal adenocarcinomas, and they may be endocrine tumors. So cystic tumors may be serous cystadenomas or mucinous cystadenomas or IPMN, which stands for intraductal or IPMN, which stands for intraductal papillary mucinous neoplasms. Okay. Now next is pancreatic ductal adenocarcinomas, and these are actually the most common malignancies of the pancreas. And the last one is endocrine tumors, which may be either an insulinoma, a gastrinoma, or even non-functioning endocrine tumors. Okay. So I'll be talking about pancreatic ductal adenocarcinomas in this session. So first of all, the problem with pancreatic ductal adenocarcinomas is that these are very aggressive tumors. First, second, they usually have a very poor prognosis with 5-year survival of approximately 5%. Okay, 5-year survival of 5%, and they are actually the fourth most common cause of cancer deaths worldwide. Okay. Now coming on to the risk factors for pancreatic ductal adenocarcinomas. So smoking is one of the most important and well-known risk factor for pancreatic ductal adenocarcinomas. Others are use of alcohol, presence of chronic pancreatitis, especially hereditary pancreatitis or autoimmune pancreatitis. Now you might remember from our last session where we have discussed about chronic pancreatitis, that chronic pancreatitis may lead to pancreatic adenocarcinomas. Okay. So chronic pancreatitis is an important risk factor for development of pancreatic adenocarcinomas. Now other risk factors are obesity, presence of diabetes mellitus is also considered to be a risk factor for pancreatic ductal adenocarcinoma, but it is not a very well proven hypothesis. Then there are several hereditary causes which are, so there are several syndromes which may lead to pancreatic adenocarcinomas. For example, Lynch syndrome or HNPCC, ataxia telangiectasia syndrome, Peutz Jeghers syndrome. So you need to remember these syndromic, hereditary syndromic conditions which may predispose to pancreatic cancers. Now coming on to the clinical features. So depending on the site where these tumors are arising, there may be different kind of presentations. So this is the pancreas here. So suppose the tumor is arising from the head of the pancreas, the presentation will be different. And if the tumor is arising from the body or tail of the pancreas, the presentation will be different. Okay. So whenever the tumor is arising from the head of the pancreas, these tumors may present as, first, there will be obstructive, painless jaundice, which will also be accompanied by pruritus or clay colored stool. Okay. Other non-specific complaints, like there may be loss of appetite or loss of weight. There may be pain or discomfort in upper abdomen with nausea or vomiting. Now, one very important clinical feature or a presentation which you all need to remember is that it has been found that in a patient who is an elderly patient and he comes to us with recent onset diabetes mellitus, and the patient does not have any risk factors for diabetes. For example, the patient is a normal weight, a non-obese male or female, a non-obese patient without any family history, and he is presenting to us with a recent onset diabetes mellitus, and the patient's age is towards fifth or sixth decade of life. These patients may have a pancreatic cancer. Okay. So sometimes pancreatic cancer may also present as a recent onset diabetes mellitus in an elderly patient without any risk factors of diabetes mellitus. For example, they may not be obese, there is no family history, but the patient has presented with a recent onset diabetes. Okay. Now, whenever the tumor is arising from the body or the tail of the pancreas, these patients are usually those who present to us late in the course of the disease. So, these are those unfortunate patients who present to us late in the course of disease. Why? Because there is no jaundice, or there is no these patients usually don't have any symptoms while the disease is in the early stages. In the late stages, they may present as pain, abdomen, or non-specific symptoms like nausea, vomiting, loss of appetite, or loss of weight. Now, one thing here is, whenever a patient of CA pancreas presents to us with severe back pain, then it means that disease has advanced and it has involved the retroperitoneal nerves, and so it is usually an advanced disease. Now coming on to the signs. So as we have already discussed, there will be jaundice or icterus in patients who are presenting late in the course of the disease. We may have a palpable mass. In cases of metastasis, we may have ascites, or in case of liver metastasis, there may be hepatomegaly. Then on a per rectal examination, in cases of METs, on per rectal examination, you may find Bloomer shelf. That is, you will be able to feel peritoneal metastatic deposits on per rectal examination, or there may be a Sister Mary Joseph nodule. What is this? This is basically a periumbilical lymphadenopathy. This also happens whenever the disease has metastasized. Or there may be a Virchow's node. What is this? This is a left supraclavicular lymph node. So, whenever the left supraclavicular lymph node is positive, then it is again a sign of metastatic disease. Now here I would like to talk about a very important sign which we have already discussed while we were discussing cholangiocarcinomas, and that is Corbusier's sign. So whenever the carcinoma is present in the head region, then we may find a palpable gallbladder. Okay. So what is Corbusier's sign? Corbusier's sign or law states that in a patient who has obstructive jaundice with a palpable gallbladder, the condition is unlikely to be due to choledocholithiasis or stones. And so we have to think about more sinister diagnosis, for example, a carcinoma in the distal CBD or pancreatic head. Okay. So we may find a palpable gallbladder along with obstructive jaundice. So this is an important sign here which you all need to remember. And the DD of palpable GB with obstructive jaundice will be a periampullary carcinoma. And what are periampullary carcinomas? So what happens is that we have already discussed in our last sessions about distal cholangiocarcinomas, and in this session we are discussing about pancreatic cancers, and especially the pancreatic cancers that arise in the head. So these are basically, these periampullary carcinomas are those cancers So periampullary carcinomas are, first, they may be a CA of the head of pancreas, that is the tumor is arising anywhere in this head region. Okay. So this is one type of periampullary carcinoma. Second is a distal cholangiocarcinoma. That means the tumor is arising in the distal part of the CBD here. Okay. So this here is distal cholangiocarcinoma. This here is CA head of the pancreas. Third one is carcinoma of the ampulla of Vater. That means this area here is carcinoma of the ampulla of Vater. And the fourth one is duodenal adenocarcinoma. That means anywhere inside the duodenum the tumor is arising. So anywhere inside the duodenum the tumor is arising and it is obstructing the ampulla of Vater. So why is this term a periampullary carcinoma used for as a constitutive term for these four tumors? Because all of these four tumors or periampullary carcinoma, they have a similar management, that is pancreaticoduodenectomy, and in many cases it is difficult to diagnose pre-operatively what is the actual site of origin of the tumor. So you have to remember this term here, periampullary carcinoma, and what all cancers they are present inside this periampullary carcinoma term. Now, out of these, CA head of the pancreas is the most common diagnosis of periampullary CA, and distal CA is distal cholangiocarcinoma is the second most common. Okay, so these are all important questions which may be asked in your examinations. Now, coming on to how to diagnose a patient of pancreatic ductal adeno CA or CA head of the pancreas. So, a contrast enhanced CT abdomen is the mainstay for diagnosing CA of the pancreas, and it gives us very important information regarding the tumor. First of all, the tumor size, its extent, whether it is invading any adjacent structures. So, it will give us information about the size, any adjacent invasion. Second, it gives us very important information regarding the vascular invasion, and this is important because we have to decide whether the patient has is a candidate for surgical treatment or not. So this information is very important for of course diagnosing the disease, but also for planning the management of the patient. It may give information regarding lymph node status, all local as well as metastatic lymph nodes, and any ascites or hepatic metastasis. Okay. So these are all the important information that we get from a CT of the abdomen. Now, what is the role of ERCP? So, friends, whenever we are not able to find any lesion on the CT scan, then in those and the patient has obstructive jaundice, in those cases, ERCP is important investigation, as it can diagnose small ampullary lesions which are missed on CT scan first. Second, it also plays an important role in as a therapeutic tool. So, whenever a patient has presented to us with obstructive jaundice and cholangitis, in those cases, we have to do ERCP and stenting. So, as a therapeutic tool, whenever we have a patient with cholangitis, or as a palliative therapy in metastatic patients with severe obstructive jaundice. Now, endoscopic ultrasound plays a very important role in cases where we have doubt regarding malignancy. So, suppose we have a patient who has chronic pancreatitis and there is a mass present in the CT scan, but we have doubt whether this is a malignant mass or not. So in those cases, we have to do an endoscopic ultrasound plus we can take a FNAC. Okay, so this will give us a tissue diagnosis in cases where we are doubtful regarding the presence or absence of malignancy. Now, staging laparoscopy is now a standard treatment, a standard management plan for patients with pancreatic adenocarcinomas. Why? Because because it has been found that CT scan, though, is a very good investigation, but it has chances to miss out peritoneal metastasis, and so before taking up the patient for laparotomy and formal resection, we can do a staging laparoscopy, and we can decide whether the disease is resectable or not, whether there is any presence of peritoneal metastasis or small hepatic metastasis. So this will help us in avoiding negative laparotomies, and so it is now an integrated treatment option for management of pancreatic adenocarcinomas. Now the question is whether there is any role of pre-operative biopsy of the tumor. So the answer is no. Whenever we are seeing a patient who has a definite mass in the pancreas, and we have ascertained that the tumor is resectable, we have to resect upfront. There is no need of any tissue diagnosis in the patient who has a resectable disease. But yes, in cases where the disease is unresectable, where it has metastasized, in those cases we have to take a biopsy and to start the chemotherapy. So it is required only in metastatic non-operative candidates, metastatic in diseases who have proven metastasis, and these are non-operative candidates to start chemotherapy. Now, a very important tumor marker, that is CA19-9, which you all should remember. CA19-9 has got an important role in management of CA pancreas. It is required for, so we have to get it done as at baseline and then for surveillance. Okay. So before taking up the patient for resection, we have to get a CA19-9 done, and then during the follow-ups we have to repeat it so as to know whether the tumor has recurred or not. Okay. So it has a mainly it does not have any diagnostic importance, but it has an importance in surveillance and follow-up. For metastatic workup, we have to look for any metastasis inside the chest. So a chest X-ray needs to be done in every patient, and suppose we have any doubtful nodule, then it has to be followed by CT of the chest. Now coming on to management of CA pancreas. So again, the treatment is divided into whether the tumor is arising from the head or uncinate process part of the pancreas, or from the body and the tail of the pancreas. So I'll just try to make a diagram and then we will discuss. Okay. So whenever the disease is resectable, and what does a resectable disease means? That the tumor is limited to pancreas, there is no invasion of any of the vascular structures, that is SMV or portal vein or SMA or celiac trunk. Okay, so all these cases are considered to be resectable, and in these cases we have to do a complete R0 resection, and whenever the tumor is arising from the head part of the pancreas, that is the tumor is here, we have to do a pancreaticoduodenectomy. Pancreaticoduodenectomy, which is also known as classical Whipple's operation. Okay, so you should all remember this surgery here, that whenever the tumor is arising from the head of the pancreas, or for that matter, as we have just now discussed, that all periampullary carcinomas. Periampullary carcinomas means either the CA head of the pancreas, distal cholangiocarcinomas, tumor of the ampulla, or duodenal cancers. In all these four cancers, the treatment is pancreaticoduodenectomy or Whipple's operation. And what all do we remove here? So we remove the head of the pancreas. This area has to be removed. Distal CBD has to be removed. This duodenum has to be removed. And then we have to do the reconstruction. Reconstruction consists of hepatico-jejunostomy, gastrojejunostomy, and pancreatico-jejunostomy. Okay. So this is all that you should remember regarding Whipple's operation. I'll be taking another session where I'll be discussing Whipple's operation or pancreatico-duodenectomy in much more detail. Now this is for the CA head of the pancreas. Now whenever the tumor is present inside the in the body or the tail part of the pancreas, in the body or tail of the pancreas, the treatment is distal pancreatectomy with splenectomy. Okay. So I hope this is all clear. You need to remember these two surgeries for CA pancreas. Now coming on to metastatic disease. So here I would just like to discuss about two more things. That first of all, what is the resectable tumor? So we have already discussed where that the tumor is present inside the pancreas. It is not invading any adjacent structures, and all the vascular structures are free. The tumor is resectable. So there is something called as unresectable tumor. So unresectable tumors are whenever the tumor has involved celiac trunk or superior mesenteric artery, the tumor is considered to be unresectable. Whenever there is metastasis, that is either peritoneal mets or hepatic metastasis or distal lymph nodes, distant lymph node metastasis, in those cases the disease is unresectable. And in such cases, the treatment is chemotherapy or palliation. Okay, chemotherapy or palliation. Chemotherapy, the routinely used chemotherapy regimen is FOLFIRINOX, which is 5-FU, so chemotherapy regimen is FOLFIRINOX, which consists of 5-FU, oxaliplatin, irinotecan, and leucovorin. Okay. And palliation may be required for patients who have severe jaundice, and the treatment for jaundice will be ERCP with stenting. Patients in huge patients who are having a huge growth, they may also present with gastric outlet obstruction. So these patients may benefit from endoscopic stenting, or surgically we can do a gastrojejunostomy. Okay. So this is what you should all remember. Now one thing more which I would like to mention here is that there is a role of adjuvant chemotherapy in CA pancreas. So whenever we are doing, we have patients who have a resectable growth, we have to do resection plus chemotherapy. Okay. Role of chemotherapy. So we have to do resection. We have done a Whipple's operation, and then we have to do adjuvant chemotherapy to the patient, which can be given by drugs gemcitabine or 5-FU. Okay. So friends, I hope this is all clear to you all. So the important points in a CA pancreas which you all should remember is, first of all, what all constitutes a periampullary cancer. So we have already discussed that there are 4 types of cancer. These cancers have a very poor prognosis, and whenever the patient comes to us late, especially in patients who have the tumor of the body or the tail of the pancreas, these patients will usually have an advanced and unresectable disease when they present to us, and so these patients will not be the candidates for resection. Third, whenever we have a patient who have CA of the head of the pancreas or any periampullary CA, the treatment is pancreatic duodenectomy followed by adjuvant chemotherapy in the form of 5-FU or gemcitabine. Whenever the patient has a tumor of the body or the tail of the pancreas, in those cases we have to do a splenectomy plus distal pancreatectomy. In patients who have metastatic disease at presentation, we have to give them palliative chemotherapy in the form of FOLFIRINOX. And patients who need palliation because of severe jaundice or gastric outlet obstruction, we have to manage them accordingly with ERCP for jaundice and endoscopic stenting for gastric outlet obstruction. So friends, I hope this is all clear. Thank you.